Has your doctor talked to you about an endometrial biopsy? You want to know what that is? Well, today we're going to talk about the endometrial biopsy, what it is, and why do we do it. Welcome back to my channel. I'm Dr. duPont. I'm a board-certified gynecologic oncologist, and I'm passionate about educating women to lead healthier, more productive lives, and I believe that begins with great health. Well, today we're going to talk about the endometrial biopsy. It's a very common office-based procedure. We do it because of abnormal bleeding, postmenopausal bleeding, if you have atypical cells, mainly glandular cells on your Pap test, or if you have something called Lynch syndrome, we'll use it for screening for endometrial cancer. Those are some of the most common reasons why we do the endometrial biopsy. When your doctor is talking to you about the procedure, they'll explain why they feel you need the procedure and what the goal of the procedure is. The other reason we do endometrial biopsy is to evaluate the response to hormone therapy. So I've had some patients, over the years that had early cancer in the uterus, and maybe they didn't want a hysterectomy because they wanted to have children. Well, the other reason I do an endometrial biopsy is to evaluate their treatment plan. So let's say they're on an oral hormone. I want to make sure that that hormone's working and the cancer's not progressing. So those are some of the most common reasons. Well, the procedure's done in the office. Typically, I'll tell patients to take a nonsteroidal like Motrin or Tylenol an hour before the procedure. Your doctor may give you a medicine to soften the cervix. That's done sometimes as well. And then the doctor will talk to you about the procedure and get consent for the procedure. You're placed on the exam table just like you would for Pap tests. Really explain it that's very similar to having a Pap test. A speculum will be placed in the vagina, and that's to separate the vaginal tissue so we can see the cervix. Next, your cervix is cleaned with betadine or an antiseptic solution to prevent infection. And typically we'll use a small device called a pipelle, or there's many different brands, but a small little instrument that I kind of describe as like a straw-like instrument. It's actually smaller than a straw. And we insert that in to be able to get the biopsy. So when we're thinking about the uterus, okay, here's my nifty uterus, we're going to put the pipelle inside to get tissue. So what this does, it has like a little plunger that you pull back, and as you pull back, you grab a little bit of tissue from the wall. So really it is a biopsy. It's not going to sample the entire endometrial cavity. It's not going to be able to look at anything. So sometimes your doctor will do this procedure with a hysteroscopy, and I do have a video on that. If you're interested, please watch that next. Well, after the biopsy's done, sometimes your doctor may need a tenaculum depending on the location of your uterus or your cervix. The tenaculum is a little instrument that's a metal instrument. Looks like this, and we'll put it usually on the anterior lip, maybe the posterior lip, depending on the position of your uterus, and that helps us straighten out the canal. So once we have the biopsy, we'll put it in fixative, and I have some here. The fixative is a preservative, and we send that to the pathologist so that they can look at it under the microscope, and they'll be able to give us a diagnosis as to, is the uterine lining healthy? Are there any precancer conditions such as uterine hyperplasia? Is there endometrial cancer? That's usually what I'm looking for when I'm doing an endometrial biopsy. So the procedure is very safe. Some of the reasons why we stop the procedure or can't do the procedure would be cervical stenosis. And so I explain that as the opening in the cervix is very scarred and I can't get this little instrument in. As you can see, this instrument is very flexible, so it's not very stiff. So if the opening is scarred, then I can't get the instruments in, and sometimes I can't do the procedure in the office. Now, usually people ask me, well, why is my office stenotic? And we don't always know. Sometimes it just happens. I do find in older people, sometimes it's just stenotic for no reason. Prior surgery, such as DNC or colon cone or leak, can also cause stenosis, but sometimes we don't always know why. And then you can also have things that are blocking the opening of the cervix, such as like a low-hanging fibroid where you just can't get the instrument in. That does happen. The other thing before we do the test is we always check for pregnancy tests. Of course, if you're 80, we're not going to check a pregnancy test. But if you're young and during your reproductive childbearing years, we will check a pregnancy test because that's one of the contraindications of this procedure. It's actually the main contraindication is a pregnancy. So we always do that first. That'll depend on your age. Most of my women are older, so they're past the childbearing age. But if I have a younger patient, definitely I will check a pregnancy test unless they've had like a tubal or something like that. Other complications of the procedure is that you'll have some cramping. So the reason we give you the nonsteroidal in the beginning, either Motrin or Tylenol, is to prevent cramping. The procedure does cause some discomfort. Most women tolerate it well. We don't typically use anesthesia for this. Sometimes, your doctor may put some numbing medicine or use a spray, a hurricane spray, but typically most women tolerate it well. But it can cause cramping and it can cause infection. That's less likely, and I almost never see it, but it is listed as some of the complications with procedure, either infection, uterine perforation, which I've never seen happen, but it's possible because these instruments are very flimsy and flexible, that typically you don't poke a hole in the uterus, and that's what uterine perforation means. And then sometimes, those are kind of the main ones, but of course bleeding. You will have bleeding after the procedure. Using that tenaculum can also cause bleeding because we kind of grasp the anterior part of the cervix, and when we remove that instrument, sometimes you'll have some bleeding. A lot of times that bleeding will stop with just pressure and time. I usually will watch my patients for about 5 to 10 minutes after the procedure in the office just to make sure they're doing okay, make sure they're not having any cramping or abnormal bleeding. Oftentimes I'll put silver nitrate, which is a hemostatic agent, on the area where that single tube tenaculum was, and that also helps with bleeding. But overall, most patients do really well. Your doctor may tell you after the procedure to avoid intercourse for several days, may tell you to avoid tampons or swimming, and that's just to reduce infection, and that's usually just for a few days to a week. Typically, your doctor will see you back or give you a call with the results. Usually in 1 to 2 weeks, we'll have the pathology report to be able to tell you, why you're bleeding. Now, sometimes when I get the pathology report, it'll say no endometrial tissue. Now, if there's no endometrial tissue and I'm worried that the person's having bleeding, then sometimes I do have to do a D&C, and that's usually done in the operating room. I do have a video on that, so if you're interested, continue watching. But if you don't have any endometrial tissue, a lot of times that means that for some reason you just need another biopsy. Now remember, this biopsy doesn't sample the entire uterine cavity, so I tell patients, sometimes pathology can be missed. The endometrial biopsy is very sensitive for uterine hyperplasia and endometrial cancer. It's not as sensitive for polyps, so sometimes I'll get pathology, it'll say, a fragment of a polyp. Typically, the endometrial biopsy won't remove that whole polyp. And so a lot of times if you have polyps, you can still have pathology that's in that polyp that was not able to be sampled by the endometrial biopsy, because remember, it's just a sample. It's not the entire endometrial cavity. And I have had patients over the years where, I've done endometrial biopsies, I've done D&Cs, and if they're still bleeding, a lot of times I do have to talk to them about a hysterectomy, because sometimes you just have to take the whole uterus out to be able to make sure the patient's symptoms stop, or to make sure there's not a cancer that's being missed. Because even though with the endometrial biopsy, you can miss some areas of the uterus that aren't picked up. It's just because the biopsy is just a quick, simple procedure. I hope that was helpful. If you have any questions, put them in the comments below, and I'll see you in the next one. Bye-bye.